sorry, there was some confusion in the last video. So why do enthesiophytes form? It's for a number of reasons. The deep digital flexor tendon, the collagen fibers inside of it can start to fray. What you can also get is adhesion between the tendon and the bone in the navicular region. You can also get crevices, so dips and splits in the deep digital flexor tendon, maybe because of abrasions and things like that. Even, how do I say this? Focal fibroplasia can be the reason. Anyway, just to avoid confusion. So yeah, there are other diagnostic techniques, of course, CT, scintigraphy, MRIs. So here it's very obvious that you can see the injured navicular suspensory ligament. That can be one reason for this disease. And treatment, there isn't a cure, which is awful. And rest doesn't entirely help. The horse should be encouraged to weight bear the foot in order to improve blood supply. So it's like the opposite of laminitis. You don't want too much weight bearing. Here you want more weight bearing, and you do this by widening the heels in the shoe and to increase the elasticity of the heel region. We'll discuss more about it. So usually in terms of clinical signs, you'll improve the clinical signs by corrective trimming and shoeing, and you'll often see improvements in 6 weeks. And in terms of the prognosis with this disease, it's difficult to predict because of bone and soft tissue abnormalities, like I just mentioned. So we'll talk about different treatments, really. So there's corrective trimming and shoeing. Why do we do this? So we want to restore normal foot pastern axis. We want to correct foot problems so we can shear the quarters, the heels, things like that. We want to widen and support the heels. We want to reduce forces on the navicular region, which is one of the main reasons that it occurs, and to ease breakover. So how do we do this? Proper trimming. So the heel should be trimmed to the, so you know the frog is like a triangle shape. It should be trimmed to the widest part. The heel should be trimmed to the widest part of the frog, and the toes of the shoe or the hoof should be shortened to shift the weight bearing onto the back of the foot. So basically you want more hoof at the back because you want the weight bearing to go in the heel. And you have multiple types of shoes for this, and one type of shoe can't be used in every horse. So for example, it says here, if you have a horse with a low heel, so the heel's going down like this, and long toes, they might actually benefit from an elevated heel, so less weight bearing on the heel, whereas a horse with a narrow upright foot may actually benefit from hoof removal, heel removal, sorry, and using a flat or egg bar shoe. So let's look at this. So the egg bar shoe, we already discussed this already, but it has a different person in navicular disease as opposed to laminitis. So egg bars, these are shoes with bar extensions that basically increase the length of the toe heel axis. What does that mean? So when you increase the length of the toe heel axis, this leads to the center of the pressure to shift caudally. So these shoes are usually recommended where, let's say, the hoof capsule isn't stable, or maybe in horses with severely underrun or collapsed heels. The shoe should be applied so it's clearly visible at the quarters and extends far enough primarily to cover the heel. So basically it should look like this, like you should be able to see it. Now in terms of heel elevation, using, so like you can see this has like a wedge. This elevates the heel. So heel elevation using wedge pads or wedge bar shoes have been shown to decrease the tension in the deep digital flexor tendon and reduce pressure as well to the navicular bone and the load to the forelimbs, and to reduce the stresses of the hoof capsule. So those are the reasons. Now, these are very interesting shoes. When you have rolling, rockering, or squaring off of the toe of any of these shoes, so these are several shoe types where you can see the toe is squared off in each and every one. Why do we square off the toe? It enhances breakover, and heart bars in particular support the heels. So they reduce the forces acting on the navicular bone and the deep digital flexor tendon. So you can see the navicular bone and the deep digital flexor tendon, these are the focuses of our treatment most of the time. So other things we can give as well for lameness and reducing inflammation are like NSAIDs, so phenylbutazone, carprofen could come up, and vasodilatory drugs like isoxsuprine and pentoxifylline, things like that. I won't really go into it, but yeah, you also have Equine, oh, whatever that is. And you also have tilludronate, osphos. So this reduces bone resorption. And yeah, let me just see if there's anything I may have missed. Okay, so it can be used in laminitis. It can be combined with NSAIDs, this one. But yeah, the response isn't always great if there are major, let's say, X-ray changes seen. Now, when we give intrabursal medication, so for example, it's mentioning methylprednisolone acetate or tramnicolone, or sometimes they can be combined with hyaluronan. This is how it's basically administered. So you can see under the deep digital flexor tendon, you kind of have to stab into there, next to the navicular bone. And yeah, this is what it looks like. And it says the mean duration of soundness after injection is, it says 4 to 6 months in one study. So I think what it basically means is you see improvement in 4 to 6 months. Now, surgically, there are 4 ways, I believe. Yep. Okay, so navicular suspensory ligament desmotomy. And yeah, this procedure is close to the DIJ, so we can see that it's a joint of sorts. The inferior check ligament desmotomy. So this usually occurs with horses who have dorsal palmar hoof imbalance, a broken backward axis, and upright heel formation. So basically the heel is too high. And what else? Palmar digital neurectomy. So we do this when other options have failed, basically, because you have complications, and you also have a number of techniques. You have the guillotine technique, so you have a sharp transection of the nerve and a segment of the nerve is removed. Laser neurectomy using, let's say, carbon dioxide. Pull through a stripping technique, epidural or perineural capping, silicone capping, cyanoacrylate glue capping, radioactive ligatures, and intramedullary anchoring of the nerve. So I've just mentioned all of them, so maybe you'll remember them. And endoscopy of the navicular bursa. So let's talk through each procedure. So navicular suspensory ligament desmotomy. What the hell is that? Okay, so what you have is when you have, let's say, flexor cortex defects, the proximal border enthesophytes, mineralization of the deep digital flexor tendon, medullary sclerosis. They don't actually work as well with this procedure, but you can use it for them. And the way it works is basically the ligaments are transected using an open approach. So you can see the navicular suspensory ligament is going to be cut now, and you transect the ligament deep to the cartilage. And when they're transected using an open approach in the pastern region, you do this below the attachments to the proximal phalanx, basically. Now, in terms of the next procedure, the inferior check ligament desmotomy, it's a bit different. So the surgery helps to reduce the compressive forces on the navicular bone. And the way it does this is by reducing, so some of the forces of the navicular bone, some of them can actually come from the contraction of the deep digital flexor muscle, because this contraction is stronger with horses with navicular disease. The reason they do this is to unload pressure on the heels. So yeah, you basically cut it open sort of here. You can see that it's like the side of the leg laterally, and you find this is the superficial digital flexor tendon, this is the ligament, and basically you have to uplift the paratendon and resect it. Okay. And you have the palmar digital neurectomy. So this is the most significant complication. So neurectomies, we said this is a last resort because it leads to complications like rupture of the deep digital flexor tendon. You can have regrowth of nerves, resulting in lameness again, neuroma formation, and infection within the foot that goes unnoticed. So that's why we don't always do it. And you have endoscopy of the navicular bursa. So these are for horses with, let's say, known or suspected abnormalities on the flexor surface of the navicular bone. So let's say abnormalities like flexor cortex erosions or deep digital flexor tendon lesions like dorsal abrasions where the navicular bone is. These are the perfect candidates for navicular endoscopy. And we'll end it there before we start the next one.